This video presentation is to review Chapter 41 for Nursing 150. In Module 2, we started talking about the bone marrow and where all the blood cells come from. The red blood cells, the white blood cells, and the platelets all are formed in the bone marrow. All of these cells initially start out as blood stem cells. That's what they are referred to as they are immature. And then as they mature, they sort of specialize into the cell that they're going to be. And it's amazing the number of cells that are produced on a daily basis. About 1 billion white blood cells per kilogram of body weight are produced a day, 2.5 billion platelets, and 2.5 billion red blood cells. So it's pretty active. And as we grow older, this activity slows down. And the bone marrow of the flat bones, such as the sternum, the skull, the pelvic, and the shoulder girdles is where most of the stem cell production occurs. As far as jobs for these cells, the red blood cells are our carrier of our oxygen and some nutrients to our tissues. The white blood cells we've already talked about. That's how our protective mechanisms. The platelets are our clotting factors. These accessory organs, the spleen, can help store a lot of our white blood cells. A lot of our red blood cells also can be stored in the spleen. And the liver is a way of breaking down the old red blood cells. And they also have the liver also has a part in platelet production and blood clotting. Blood clotting, like I said, platelets are the number one thing that we have in our body that is in charge of blood clotting. It's a very complex process, the blood clotting process, and it's all done to maintain hemostasis. We need to be able to have a balance to where our blood is not too thick, but it does clot whenever we have an injury. So it has to be a good balance there. Platelet aggregation is a term that refers to forming a platelet plug by having the platelets clumped together. And this is essential for blood clotting. So that's the purpose of your platelets. And we have to have a good balance of the number of platelets that are working and functioning well in order to make sure that we do not have too much clotting going on and that we don't have too little. So there has to be a good balance there, like I said. Review table 41-2 on 860 in your Iggy book. It talks about the clotting factors. It talks about fibrinogen, calcium plays a part in blood clotting. Do not spend a ton of time memorizing it. Just review it. You should have just kind of a basic idea of all the different pieces that are involved in the clotting processes. Because it kind of helps you understand sometimes what we use anticoagulants for, where they work. A lot of them work in different areas of the clotting cascade. So just have an understanding that there are multiple things involved in clotting. And it's a very complex process, basically. There's also a summary of blood clotting cascade in figure 41-4 on page 859. Again, do not take time to try to memorize it. Look it over so that you've seen this before and you have an idea of what goes on when a patient's blood is clotting. This is just another picture. This is straight out of your book, and it's talking about the process of fibrinolysis, which is basically the process that limits our clotting. So like I said, it has to be a nice balance. So once we might form a clot, in the event that we have an injury, we form the clot so that we don't bleed to death. And then fibrinolysis comes in and it actually prevents this clot from getting too big. Because if the clot gets too big, then you could also occlude a vessel and then you have a large blood clot that we all know could lead to a life-threatening situation. So again, it's all about the balance. We have a cascade that helps us to clot when we need to clot, and then we have a balance that can stop us from clotting too much. Just kind of review this assessment of a patient just to determine, doing a patient history to determine whether somebody is at risk for having a blood disorder. It's the things like basically what they kind of look like. If they're pale, that could tell us that maybe they're anemic. They might not have enough blood cells. If their skin's dry, if they don't look like they're getting enough oxygen to the tissues, things like that. Then also, of course, asking them about a family history, if they have any history of any kind of a genetic disorder that might cause any kind of a blood clotting disorder or anemia. It's very important to understand that a nutrition status can also affect someone's health and stem cell production and blood cell production. The production of a lot of these cells requires some iron and lots of different vitamins play a role in the process. So if somebody does not have an adequate nutritional status, then that could lead to some anemias and other blood dyscrasias. One thing to point out is that you'll hear this in multiple situations about alcohol consumption. A lot of times alcoholics, people who have a high alcohol consumption, there's no nutritional value to alcohol, so they will quite frequently be nutritionally depleted, and so they will show signs of someone who is anemic, which anemia means that you have a low red blood cell count. So it's just your nutrition status. The really big bottom line here is your nutrition status can really affect what your general health is, and we know that, and it can very much affect your hematologic system as well. So the hematologic system really affects all of your body systems. So just make sure you have an understanding of what to look for in each body system. You know, respiratory assessment, if somebody is having frequent episodes of shortness of breath, that could make you maybe look further to determine what the cause of that is, and it could be a low blood count. So just be sure to review the assessment of a patient for hematologic system problems. And this is just further body systems. And just look at each body system and kind of review in your book as to what those indicators could be. Again, like for skin, it could be pale nail beds, paleness, dryness, bleeding. You know, look to see if they have excessive areas on their skin, like excessive bruising can be an indicator that there might be some hematologic issues. Ecchymosis, hemorrhagic lesions. Petechiae is a term that you need to kind of familiarize yourself with. Petechiae means those tiny little dots that they get that look like maybe tiny little pinpoints. Those are petechiae. So just make sure that you're aware of some of that terminology. There is a wonderful table on page 865. Chart 41.3, it goes through all the laboratory tests that we can do to assess a patient who we suspect might have a hematologic problem. Of course, we talked about the complete blood count. Make sure you familiarize yourself with the complete blood count and the normals for that. White blood cells, red blood cells, and your hemoglobin and hematocrit. Make sure you have an understanding of what all of those do. We've already talked about the complete blood count. It talks about your red blood cells. And we know that the red blood cells are what carries oxygen to the tissues and some other nutrients to the tissues. So we need to have adequate red blood cells in order to be oxygenated well and so that the tissues can have oxygen to them. White blood cells we've covered pretty well as far as the immune system. Platelet count, we need to have a normal platelet count in order to have proper clotting of our blood. If we have too low platelets, then our blood is going to be super thin and we're going to be at risk for bleeding. If your platelet count is too high, you could be at risk for clotting. So normal is on that chart there, it's 150 to 400,000, so make sure you're familiar with all those normals. Iron is another test that we look for in order to assess to see if a patient is anemic. There are lots of different reasons for iron deficiencies, and we'll talk about that in the next chapter and presentation, but that's another lab test that we would do in order to determine if someone is having a hematologic problem. few others are listed. Prothrombin time is a clotting time. That's how we tell how well our blood is clotting. Make sure you review that. Something called an INR is a kind of used interchangeably with PT or prothrombin time. What they did is they came up with this international normalized ratio, which is INR. That's something that you need to make sure that you look at and understand. Basically, that's how we determine whether someone is therapeutic on an anticoagulant. Their INR. It's basically an international number. If you've noticed, some of the values of labs change kind of according to which lab you're looking at, which laboratory has their own normals. But since this number has to be so accurate, they came up with this international normalized ratio so that we all are looking at the same number across the board. And basically the normal ranges for INR is 0.7 to 1.8. That's the normal person. And we'll talk about, as we go through some more talking about anticoagulation throughout the course of Nursing 150, we'll talk about what they actually determine if they want to have somebody anticoagulated. They actually want that number to be a little bit different, but that's a little bit different situation. The other one is PTT. Just gotta circle that. That's another clotting time lab that we will need to look at when we're looking at someone's clotting factors and how thin their blood is and how anticoagulated they are. Other tests to review for this is a diagnostic test, is the bone marrow aspiration and biopsy. So if we determine that someone has a problem as far as like they have a chronic low red blood cell count or a chronic low white blood cell count, the problem could be in the bone marrow. If we cannot identify any other problems with the patient, so maybe we did that head-to-toe assessment, their diet's good, they don't have a family history, they don't have a liver problem, and so now we look and say, maybe the problem is in the bone marrow. Maybe this person's bone marrow is not producing blood cells like it should. It's not making that 2.5 billion red blood cells a day like it should. So what we can do is we can actually go do a bone marrow aspiration where they actually take a needle into the bone marrow and pull out and test for the amount of stem cells that are present. Typically they do the long bones because, like we said, that's where most of the stem cells are produced. The one that they typically use for this test is the iliac crest, so it's kind of like your hip bone. And this it's a pretty quick test, but it can cause some anxiety because there is a bit of discomfort that goes along with this. And so they just need to be prepped well, and then a lot of times they'll give them like a little bit of sedation to be able to tolerate it. They do numb the area, but it is a little bit of a kind of a discomfort pressure that they often feel. It's kind of a heavy pushing on their hip. And it's, like I said, it's fairly quick, but it's a little bit uncomfortable, but typically it doesn't take too long, and people usually tolerate it well, but sometimes they're anxious, so it's the nurse's job just to determine their anxiety level and maybe ask for some sedation if they could possibly need it, and just kind of talk them through the procedure. Post-procedure, you just want to monitor the site where they did the aspiration from and just monitor it for bleeding or any signs and symptoms of infection. This is just a picture of the iliac crest right there where they'll go in and aspirate that bone marrow. It's a pretty big needle that they use, so you just kind of have to help the patient lay on their side and just monitor the site post-operatively. Their activity level is somewhat decreased for the first 24 hours. They don't want to go like running a marathon or anything. And they want to just keep it dressing on the site for about 24 hours and just monitor it. I already answered some of these questions here, but just make sure you ask yourself these questions and kind of look that up in the book so you're aware of how to care for someone that's going to have a bone marrow aspiration and biopsy. This is just a term that I wanted you to be familiar with, thrombocytopenia. This just means that they have a low platelet count. And remember before I said 150,000 to 400,000 is your normal platelet count. But like I said, just make sure you know this term. Lots of different things can cause it. A lot of times it's a liver issue could cause it. It could be maybe something wrong with the bone marrow. But just make sure that you're familiar with the term thrombocytopenia. That means a low platelet count. And that concludes the presentation for Chapter 41 in Nursing 150. The next few slides is just some questions for you to review. The answers are posted in the section, the additional information with the PowerPoint without voice.